Good afternoon, and thank you for joining today's COVID-19 Deliver Pediatric Perspective webinar, a collaboration between the AASLD COVID-19 Clinical Oversight Subcommittee, the AASLD Pediatric Liver Disorders Special Interest Group, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and the Society of Pediatric Liver Transplantation. My name is Nadia Ovchinsky, and I am pleased to be moderating today's webinar along with Dr. Emily Perito. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. This webinar is being brought to you by all three organizations' members, for our members and the collective audience within the field of pediatrics and pediatric hepatology. Our agenda for today will include some introductions, followed by 4 wonderful presentations by Drs. Jamie Chu, Mohit Kihar, Noel Ebel, and Bo Kelly. These will be followed by a lively panel discussion. You are encouraged to submit questions throughout today's presentation using the Q&A box at the top or bottom of your screen. We will answer as many questions submitted to the Q&A box as time permits after the formal presentations. We will not be taking any verbal questions during today's webinar. I'm Nadia Ovchinsky. I'm a pediatric hepatologist and the director of the transplant at the Einstein College of Medicine, Children's Hospital at Montefiore, as well as Gorey Children's Hospital in Morristown, New Jersey.
Joining Nadia today's co-moderator, I'm Emily Perito, Associate Medical Director of Liver Transplant at UCSF in San Francisco.
Our first presenter will be Dr. Jamie Chu, the Associate Chief in the Division of Pediatric Hepatology and Associate Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, New York.
Following Jamie will be Mohit Kihar, who's a pediatric gastroenterologist and hepatologist at Kingston Health Science Center and an assistant professor at Queen's University.
Followed by Dr. Noel Ebel, an assistant professor of pediatrics and the director of the Allergy program at Stanford University.
And our last speaker will be Bo Kelly, who's the surgical director and transplant surgeon at DCI Donor Services. Then finally joining us for the panel after the speakers will be Vicki Ng, a professor of pediatrics and medical director of pediatric liver transplant at Toronto Sick Kids.
And Dr. Mercedes Martinez, associate professor of pediatrics and the director of the intestinal transplant program at Columbia University Medical Center, New York Presbyterian. We're very grateful to all the input from the Clinical Oversight Subcommittee of the AASLD COVID-19. Although now it seems like years ago, it was just in early March when we started preparing for the pandemic. In New York, many pediatric providers were frantically reviewing adult medicine guidelines with an understanding that our help may be needed on the front lines to care for thousands of patients who will be coming into our hospitals. We knew that children will be infected as well and may serve as vectors bringing the virus home to their families and grandparents at risk, but everything told us kids should not get too sick. In mid-March, there was a report from Wuhan Children's Hospital that we anxiously awaited. Almost 1,400 children infected. They didn't do so bad. Only 3 ended up in ICU, all with pre-existing conditions. On March 20th, we admitted our first COVID-positive pediatric patient to the Children's Hospital at Montefiore. 1 week later, I distinctly remember being in a state of shock along with many of my colleagues. Rounding that weekend, we found out that 7 of 8 admitted kids were actually in the PICU. Some very sick, some who were previously healthy were now intubated. This was also the day I admitted our first post-transplant patient with COVID and shared it on Liver Twitter. This led to outpouring response from pediatric liver centers all over the world, sharing our experience with these rare patients. About a month and many patients later, we finally had a lot more understanding of how this disease affects children and their livers.
As we started to understand the manifestations of this infection at the end of April and early May, children started to come in, especially in high prevalence areas like New York, with this mysterious illness called that we're now calling Multi-Inflammatory Syndrome in children, or MISC-C, coming into the PICUs with respiratory distress and even heart failure. So we've seen various manifestations of liver injury, and are grateful that AASLD has allowed us this opportunity for the Pediatric Special Interest Group to collaborate with our colleagues at NASPGHAN-SPLIT to share the collective experience and discuss more what we can do to help children with underlying liver disease and to understand how COVID affects the liver.
Our first speaker is Dr. Jamie Chu, the Associate Chief in the Division of Pediatric Hepatology and Associate Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai in New York. She will be discussing liver manifestations of pediatric COVID-19 infection and MISC.
Thank you, Nadia and Emily. The focus of my talk today is on liver injury associated with COVID-19 and MISC in pediatric patients without known chronic liver disease or transplantation. I will briefly touch upon the clinical manifestations of each entity and then present data on what we know so far about the prevalence and its impact on the liver. Next slide, please. I wanted to start with an overview of the pathogenesis of SARS-CoV-2 infection to frame our discussion today, as we will touch upon treatments targeted to these pathways in the talks following mine. This is a simplified depiction of SARS-CoV-2 entry and replication. Briefly, SARS-CoV-2 enters the cell through membrane fusion or endocytosis via binding of its spike protein to the ACE2 cell surface receptor. The virion then releases RNA into the cell and forces the cell to produce and disseminate copies of the virus, which can then go on to infect more cells. The red asterisks denote key drivers in the pathogenesis of disease, which has been targeted for therapeutic intervention. For example, convalescent plasma targets the spike protein, hydroxychloroquine may have effects to block endocytosis, and remdesivir blocks RNA replication. Next slide, please. This process of viral infection leads to inflammation and immune dysregulation in multiple organs, including the lungs, brain, heart, kidney, GI tract, and the liver. This immune dysregulation has also been a target for investigational therapies such as tocilizumab, an interleukin-6 inhibitor, as well as other strategies to inhibit this inflammatory and immune-mediated response. Next slide, please. The mechanisms by which SARS-CoV-2 infection leads to liver injury are not entirely clear. Liver injury may result from direct injury to liver cells. The rationale for this hypothesis comes from limited studies demonstrating ACE2 receptor RNA expression in the liver, which was higher in cholangiocytes than in hepatocytes, but the overall expression in both cell types is not that robust. Liver injury in COVID-19 is likely to be secondary to complications of COVID-19, including myositis, where AST elevation is greater than that of ALT, cardiac injury, ischemia, or cytokine release syndrome. There may be a component of drug-induced liver injury, as many investigational drugs have known hepatotoxic side effects. And lastly, there's evidence of liver injury seen in multi-system inflammatory syndrome in children, otherwise known as MISC. Next slide. Overall, the burden of COVID-19 among children is much less when compared to the number of cases in adults. This is held true across many countries. The CDC reported that 2% of all confirmed COVID-19 cases in the United States were pediatric cases. This percentage is similar across China with 2.2%, Italy with 1.2% of all cases, and in Spain, where there was less than 1% of all cases were pediatric cases. Next slide, please. In addition to the fewer cases seen in children, the clinical course of acute COVID-19 appears to be more mild in children as well. One of the early studies published in Pediatrics was a nationwide case series of over 2,000 pediatric patients with COVID-19 reported to the Chinese CDC. The clinical manifestations of pediatric COVID-19 cases were generally less severe than those of adult patients. More than 90% of all pediatric cases had asymptomatic, mild, or moderate disease. Severe disease was defined as dyspnea and hypoxia, and the critical disease was defined as having ARDS, respiratory failure, or multi-organ dysfunction, but this accounted for really the vast minority of cases. Next slide, please. Now we turn specifically to the liver injury seen in COVID-19. For comparison, the majority of adult COVID-19 cases demonstrate mild liver injury. This recent paper in Gut described the peak levels of liver biochemistries in over 800 adult patients. The majority of COVID-19 patients have normal ALT, alkaline phosphatase, and total bilirubin levels, with a very small percentage of patients demonstrating elevations greater than 5 times the upper limit of normal for any of these parameters. Next slide, please. This seems to hold true in children as well. Children with COVID-19 have similar risk of liver injury to that of adult patients, with most studies ranging from 10 to 30% of patients presenting with an ALT abnormality. Here we see that even in moderate severity COVID-19 disease in children, the liver parameters are essentially normal. So here we have a PT, direct bili, albumin, ALT, GGT, and AST that are all essentially normal. Next slide, please. While most adults and children with COVID-19 present with mild liver injury, there is some emerging evidence from large meta-analyses of adult studies to suggest that increased ALT or abnormal liver function on admission is associated with more severe COVID disease, and that COVID-19 patients with elevated liver chemistries at some point during their hospitalization have an increased risk of adverse outcomes and mortality when compared to patients without elevated liver chemistries. Again, this is difficult to determine whether the liver injury is directly modulating disease outcomes or whether the injury is secondary to COVID-19 related pathologies, DILI, or immune dysregulation. We now turn to multi-system inflammatory syndrome in children, known as MIS-C. Here in New York, we saw our surge of COVID-19 cases peak at the beginning of April, as you can see in the blue bars. But a few weeks later, we started to see an influx of pediatric patients who presented with a Kawasaki-like presentation with prolonged fever, mucous membrane findings, rash, abdominal pain, and cardiac dysfunction, and rapidly deteriorated, often in the ERs and requiring ICU support. Surprisingly, respiratory symptoms were not a predominant feature. This later came to be termed as MIS-C. The CDC has set the definition of MIS-C to include 5 criteria: being hospitalized and under 21 years old, having fever greater than 24 hours, having laboratory evidence of inflammation, which can include ESR, D-dimers, elevated IL-6, having multi-system or 2 or more organs involved, including cardiac, renal, respiratory, hematologic, gastrointestinal, dermatologic, or neurologic involvement, and evidence of SARS-CoV-2 infection by PCR, antibody, antigen, or just having a proven exposure to actually a suspected or confirmed COVID-19 case within the last 4 weeks of symptom onset. A multi-center pediatric ICU study in New York City described the population of children with MIS-C admitted to their ICUs between the end of April and May. In contrast with the infantile distribution of Kawasaki's disease, MIS-C is predominantly a disease of older children and adolescents, here being the median age of 10 years old. Of particular interest to this audience, obesity was not a common presenting feature. Abdominal pain with nausea and vomiting was present in 60 to 70% of the cases. It is important to note, however, that only 1/3 of these patients were SARS-CoV-2 PCR positive. However, the majority, or 80% of them, were COVID antibody positive, suggesting a post-infectious entity. On admission, in particular for the liver enzymes, the majority of patients had normal ALT, AST, and bilirubin levels. It's important to know that rapid and complete clinical and myocardial recovery was almost universal. In contrast to acute COVID, where only about 10% of children present with abnormal liver biochemistries, in data from the CDC in MIS-C, about 2/3 of patients will present with elevated ALT greater than 40 at some point during their hospital course. This is the breakdown of abnormal ALT by age, but these percentages are much higher than acute COVID disease. Next slide, please. These clinical observations are similar to those reported in the UK. In this study, they followed the ALT levels through the first 4 days of their ICU stay, and from the highlighted area, you can see that ALT levels largely remain stable and only mildly elevated. Next slide, please. So in summary, liver injury is common but mild in most pediatric COVID-19 and MIS-C cases. Etiologies of abnormal liver biochemistries include myositis, ischemia, cardiac injury, drug-induced liver injury, and MIS-C. It's important to monitor for interval change of liver tests, especially in those pediatric patients receiving investigational treatments, such as remdesivir and tocilizumab. Longitudinal studies are needed to determine the long-term effects of COVID-19 in children. These recommendations and other information can be found in more detail in the AASLD COVID-19 Expert Consensus Statement, which is regularly updated. Thank you for your time.
Thanks so much, Dr. Chu. Next, we'll hear from Mohit Kihar from Queen's University, Canada, on their experience so far with the NASPGHAN-SPLIT registry on children with chronic liver disease.
Thank you, Dr. Pericho and Dr. Ovichitsky, and thank you, the AASLD Special Interest Group, for the opportunity to share the interim results from the NASPGHAN-SPLIT registry regarding COVID-19 infection in children with chronic liver disease and pediatric liver transplant recipients. In the next 7 minutes, I will present the data available on the course and outcome of children in liver disease who tested positive with COVID-19 infections. And following my presentation, Dr. Evil will present the data on the pediatric liver transplant recipients infected with COVID-19. Next slide, please. As Dr. Chu has shared, that elevated liver enzymes and hyperbilirubinemia has been previously reported in SARS-CoV-2 infection, although there is limited data available about the impact of COVID-19 in patients who have underlying chronic liver disease. And there is no data in pediatrics so far. Next slide, please. This is a study that was just published in Gut this month. A cohort of 37 cirrhotic adult patients were infected with COVID-19. They were age and gender matched with 2 comparator groups. One was a patient with COVID-19 alone, and other were the group of patients with cirrhosis without COVID-19 infection. The authors found that the mortality rate was highest in the cirrhotic patients with COVID-19 infections in comparison to COVID alone, although they didn't find any statistically significant difference in the mortality rates between the cirrhotic patients with or without COVID-19 infections. Next slide, please. Another data from international registry of over 150 adult patients infected with COVID-19 showed around 30% mortality, and the lung complications were the most common cause of death, and the liver-related complications occurred in around 12% of patients. As by now, we understand that COVID-19 affects the children quite differently in comparison to adults, and the difference in the underlying liver disease and the comorbid conditions makes extrapolation of the data of adults to pediatrics impossible. Next slide, please. To address this knowledge gap in children, a pediatric registry was created as a joint collaborative effort between the Hepatology Committee of North American Society of Pediatric Gastroenterology, Hepatology and Nutrition, and the Quality Improvement Committee of the Society of Pediatric Liver Transplant. to understand in real time the course and the outcome of COVID-19 for children with underlying liver disease and who have had liver or intestinal transplant. We included all the patients under 21 years of age with chronic liver disease and recipients of liver transplantation. And this is an international red cap registry which was launched in April of this year, and we have been sharing weekly reports through the NASPGHAN and the SPLIT list servers, and it's also available on the NASPGHAN website. We have shared the week 12 data last week, and the data collection is ongoing. Next slide. Our registry is now in its 13th week with 45 patients from 5 countries, including United States, Canada, Argentina, Pakistan, China, reported till date. Majority of the cases are from United States. Next slide, please. In United States, we have data from 9 states, including 21 centers who have reported in our registry so far. Next slide, please. To date, 23 patients have been reported with underlying disease of their native liver. The median age of the native liver group was 5 years. Three-fourths of the children are white or Hispanics. 70% of the infected patients required hospitalizations, and 1/3 required pediatric ICU level of care. Next slide. The 3 most common diseases were biliary atresia, followed by non-alcoholic fatty liver disease and autoimmune hepatitis. Amongst the autoimmune hepatitis, 2 patients were on azathioprine monotherapy and 3 were on azathioprine and steroids both, and only 1 patient had a dose reduction done for azathioprine. Next. As comorbidities can affect the outcome in COVID-19, we also collected this data in our registry, and obesity was the most common comorbidity found in our cohort, followed by failure to thrive and various GI comorbidities, including celiac disease, short bowel syndrome, and GVHD. Next slide. Around 40% of the patients presented with constitutional symptoms, including fever, myalgia, fatigue, sore throat, or loss of smell and taste. 1/3 of patients had One-third of the patients had respiratory manifestations, including cough, difficulty in breathing. Around 10% had anorexia, including 2 patients had MIS-C-like presentation. Of note, 5% of the reported cases were asymptomatic. Next slide, please. This slide shows the laboratory trends in the children with their native liver who infected with COVID-19. We found statistically significant differences between the baseline and peak white counts, ALT levels, total bilirubin, and INRs. Similarly, we also found significant differences between the baseline and nadir levels of white counts and albumin in our group. The median absolute lymphocyte count in our cohort was 2.48. Next slide. Around 40% of the patients of their native liver received only supportive therapy. As there is no generally accepted specific treatment for COVID-19, reported therapies include steroids, IVIG, HCQS, antibiotics, antiviral agents. 3 of the patients also were treated with immunosuppressive agents like IL-6 inhibitors. Regarding the steroids, we do not have any data about the specific steroid agent used, especially in the light of the recent data about the potential benefit of dexamethasone. Next slide, please. Only 3 patients required conventional or mechanical ventilation, and 1 needed high-frequency ventilation. The median duration of respiratory support was around 6 days, and 4 patients in our cohort needed vasoactive agents, and 2 needed renal replacement therapy. Next slide. To date, there has been only 1 death reported. So far, there is over 80% recovery rate in the non-transplant chronic liver disease patients. 2 patients are still active in their disease course, and only 1 reported mortality. The median time to recovery was, The median time to recovery was 7 days. The median hospital length of stay was 7 days, and the median PICU length of stay was 6 days in the patient requiring this level of care. Next slide. Finally, 60% of patients with pre-existing liver disease did not have any decompensation event. However, when decompensation did happen, portal hypertension manifesting as ascites or bleeding was the most common one. 1 additional patient developed infection. Next slide. To summarize, this is the first pediatric specific registry assessing the outcome of COVID-19 on liver disease and liver transplant recipients. Hospitalization was required in majority of cases with the pre-existing disease. with recovery was seen in majority of them, with only one death reported in our registry so far was from this group. Thank you for your attention. Now I would like to invite Dr. Ebel to share the pediatric registry data on the cohort of transplant recipient with COVID-19 infection. Thank you.
Thank you for the opportunity to present the COVID registry data for liver transplant recipients. As background, literature in the pediatric liver transplant space is currently limited to case reports or series from our colleagues in France, Italy, by our colleagues at Columbia, and from a few others that are currently in process. When we look at the adult literature, Secure Cirrhosis, partnered with COVID HEP, now in its 14th week, recently reported 160 COVID positive adult liver transplant recipients, of whom 81% were hospitalized, 29% required ICU admission, 19% required invasive ventilation, and 19% died. In the second report from our European colleagues, I included only to highlight the number of comorbid conditions in COVID-positive adult transplant recipients. What I hope to impress upon you in the coming slides is how different outcomes for our pediatric transplant recipients seem to be compared to our adult colleagues, and also to contrast the differences in outcomes in children with chronic liver disease that Dr. Kihar just presented, and how much sicker they seem to be when compared to children who are post-liver transplant. Next slide. Our registry is now in its 13th week. To date, it includes 22 liver transplant recipients that are COVID positive. Of these 22 patients, 2 were multivisceral transplants and 1 was a liver kidney transplant. 45% were female and ages were 6 months to 21 years with a median of 13.5 years. Timeout from transplant ranged from 1 week to 19 years with a median of 4.6 years. Next slide. The majority of patients were white, with around a quarter being Latinx children and 5% were Black children. Next slide. The majority of patients underwent liver transplant for biliary atresia at 36%, with the second most common indication being acute liver failure at 27%. Pre-existing comorbid conditions at the time of COVID infection included de novo autoimmune hepatitis, lupus, inflammatory bowel disease, hypertension, renal disease, and diabetes. In contrast to adult reports, none of the 3 patients reported to the registry who were admitted to the ICU had any comorbid conditions. Next slide. Related to their presenting symptoms, for patients with liver transplants only, 20% of patients were asymptomatic, 50% presented with fever, 30% had respiratory symptoms, 45% had GI symptoms, and 30% had at least one of the listed constitutional symptoms. Both patients with multivisceral transplant presented with fever, 1 had respiratory symptoms, and 1 had diarrhea. Next slide. Only 7 of 22 patients, so 32%, required admission to the hospital. This is in contrast to children with liver disease that Dr. Kihar presented, of whom nearly 70% required hospital admission. For post-liver transplant recipients, 3 of the 7 admitted patients required ICU level of care. No patients admitted to the ICU required mechanical ventilation. 1 patient required CPAP in the ICU, and 1 patient was on nasal cannula on the floor. Next slide. For the 3 patients admitted to the ICU, their number of hospital days was significantly longer than those who did not require ICU transfer. 2 of these patients were transplanted for biliary atresia and were 1 week and 7 months out from their liver transplants respectively. The 3rd patient had a multivisceral transplant for microvillus inclusion disease and intestinal failure associated liver disease and was 5 years out from their transplant. Conversely, there were 3 patients who were only 2 to 4 months out from transplant, not shown here, that remained as outpatients. Next slide. Of those with reported lab values, which was 18 out of the 22 patients, 17% developed significantly elevated ALT, around 5 to 10 times their baseline values. One of the patients with a baseline ALT of 231 was a fresh post-transplant patient. All other patients had normal transaminases at the time of COVID diagnosis and throughout their clinical course. 1 patient with a multivisceral transplant that was admitted to the ICU developed hypoalbuminemia with the albumin that went from 3 to 1.6. All other patients had normal albumin levels reported during their COVID course, with the exception of a fresh post-transplant recipient with a baseline albumin of 2.5. 1 patient with an elevated baseline INR of 2.3 developed worsening coagulopathy with a peak INR of 2.8. All other patients had normal INR levels during their COVID course. No patients had significant elevations of their bilirubin from their baseline. 1 patient had a liver biopsy and liver tissue was positive for COVID by in situ hybridization probe. Next slide. At the time of COVID diagnosis, 1 patient was on no immunosuppression, 36% were on single immunosuppression, 36% were on dual immunosuppression, 18% were on triple immunosuppression, and 1 patient was on quadruple immunosuppression. Next slide. It's challenging to draw conclusions from a sample size of 22, but to display the level of care versus the level of immunosuppression graphically, most patients with COVID remained as an outpatient in green. Of the 3 patients that were admitted to the ward in blue, 1 was on single immunosuppression and 2 were on double immunosuppression. Of the 3 patients who were admitted to the PICU, 1 was on single, 1 was on double, and 1 was on triple immunosuppression. The patient on quadruple immunosuppression remained as an outpatient. Next slide. Regarding approaches to minimization of immunosuppression in the setting of COVID, 6 patients stopped an immunosuppressive medication at the time of diagnosis, of which 5 patients stopped MMF and 1 patient stopped sirolimus. All these patients remained on another form of immunosuppression, primarily tacrolimus. 9 patients had immunosuppression doses reduced. 6 patients reduced tacrolimus trough goals. 1 patient reduced cyclosporin. 1 patient reduced steroids, and 1 patient reduced MMF. 11 patients had no changes to immunosuppression. The numbers here don't add up to 22 because 6 patients had both a primary immunosuppressive medication decreased, most commonly tacrolimus, and a secondary immunosuppressive medication discontinued, most commonly MMF. Next slide. 4 patients received a COVID-directed therapy. In the outpatient setting, 1 was treated with azithromycin, 1 was treated with steroids. For 2 patients requiring PICU transfer, 1 was treated with hydroxychloroquine and IVIG, and this was a patient that required CPAP. 1 was treated with hydroxychloroquine and favipiravir, and this is the multivisceral transplant recipient. We'd like to note that these cases treated with hydroxychloroquine were more of a relic in the past. They were used in the early part of the first COVID surge. Favipiravir was used in a patient outside of North America as it's currently only available in clinical trials. Next slide. 17 patients have fully recovered without complication, and 5 patients are still active in their clinical course. There are no reported deaths for pediatric liver or multivisceral transplant recipients to the registry. To summarize, we report the largest experience of children with liver disease and who are post-liver and intestinal transplant from the NASPGHAN-SPLIT registry, nearing 50 total patients as of this week. Notably, in contrast to children from the registry with chronic liver disease, the post-transplant recipients had no reported deaths and did not require mechanical ventilation. They were also less likely to be admitted to the hospital or require ICU care or transfer. Next slide. Our registry remains open, and we call on all of our colleagues to add all COVID positive patients with acute liver failure, chronic liver disease, or who are liver or intestinal transplant recipients to the registry. It's only by pooling details of COVID cases that we'll be able to perform the large-scale analyses that are required to inform clinical care. Data from the registry, as Dr. Kihar mentioned, is published weekly on the SPLIT and NASPGHAN websites, and it's available to the public, and we're grateful to those who have already contributed. And thank you to AASLD and Drs. Prito and Ovchinsky for the invitation to present today.
Thanks so much, Noel. Last, we're going to hear from Dr. Bo Kelly from DCI Donor Services. He's going to talk to us about re-entry into clinical transplantation during the COVID pandemic.
Thank you very much. We've heard some excellent talks framing the severity and experience of pediatric liver transplant recipients. I'd like to take the opportunity to request some poetic license in my talk to take a slightly different tact. I'd like to draw a correlation and analogy to a space mission and liver transplantation, because both require and are composed of complex dynamics, both of contact experts as well as individuals working in synchrony to perform very high-level healthcare. Any inattention to detail along this process can obviously jeopardize the entire mission. In the setting of a COVID pandemic, the delicate process has become all the more complex and certainly uncertain. And there are problems with reentry, and what we've heard are all of the science behind the development of COVID in children. But I think there's another real pressure out there that is impacting not only our ability to perform our vital service, but also impacting our parents and the community at large. So I'd just like to take a moment to compare this to an actual sort of re-entry from space, if you will. So imagine that you're in a capsule, strapped into a capsule, approximately the size of an SUV. That capsule is powered by a computer technology that's probably 1/1000th of the power that you possess in the cell phone that you have in front of you. You're hurtling through Earth's atmosphere with atmospheric particles bombarding the underside of your capsule, generating tremendous heat. And with this, there's obviously some information that you need to know exactly where you are, how to separate the noise from the actual signal of where you are, if you will, an attack angle of how you will re-enter the atmosphere at just the right time and just the right place, an appropriate attitude or orientation for your vessel to maintain its position so that you don't burn up as you accelerate through the atmosphere. With this, there's challenges in balancing the gravitational forces and external pressures that are going to impact the way in which you re-enter. In my mind, as I think about this, this is very similar to what parents and patients are going through at present, trying to distill the overwhelming majority of information that comes at them to somehow distill into making daily decisions in life. With all of this, there's some faith that we all possess that the scientists that are behind all this are developing the appropriate programming and design to allow us to make these appropriate decisions. But at the end of the day, all we really all want to do is get back home safely. Next slide, please. Well, in case you happen to be sheltering in place without internet access, I just thought I'd review for you the fact that we are now living in a country with tremendous hotspots of COVID resurgence. We thought we went through all this back in March and April, and I thought it was really paying off for me to stay home with my kids. But as it turns out, there's been just a resurgence of disease despite all that. In the second frame, what you see are all the states, and I apologize for the faintness of the picture, but basically what it's showing you is all of our states have had an increase in uptick of COVID patients. All the way to the right is a slide demonstrating what happened as we, quote, bent the curve and flattened the curve. But as we've gone back to mobility, what we've seen is there have been a tremendous resurgence of these cases just associated with our reentry back into activities of daily living. With this resurgence of cases, there's been approximately 10% test positivity in the community, despite our local governments continuing to encourage masking, social distancing, and all of the shelter-in-place practices that we've undergone. Next slide, please. So the uptake of all that is that we're finally able to do more testing, and that testing has still resulted in over 140,000 deaths. Next slide. So what are the external forces that we face? At present, within the healthcare economic community, our GDP has declined roughly 5% over the course of every month of partial closure. So for families who are experiencing, the question of why don't we just all stay home forever, there are real reasons why we can't just stay home forever as much as I would like to get past 2020. The U.S. hospital financial losses have been projected somewhere at the $323 billion mark. This has impacted services across the board. There's been obviously an uptick of unemployment in the country that peaked at around 15%, is now still in double digits, close to 10 to 11%. With that, what we've all experienced as hospital employees are layoffs, furloughs, and salary reductions, even for surgical staff not able to perform elective procedures. Many have been forced to take salary cuts. With all this, there's a parallel impact on medical training, where we've had interruptions in medical education, training programs, hospital credentialing, and certificates. So all of this adversity has exposed us to the reality of who we really are in this time and place. Next slide. So the angle of attack and what is the appropriate attitude, and to those external forces, we also have many internal forces that are impacting our daily life. As we've seen, the sheltering in place, lockdown, and social distancing has resulted in increased isolation. As an example, my parents live in a hotspot in South Carolina, and they're very isolated. They live in a community with other older individuals, and it's very hard for them to have any resources or outside communication with their community. What that's also led to is increased anxiety and depression, disruptions in family structure, food insecurities, increased adversity of child events, which of course have been associated with predictive determinants of health. All of these are resultant of lockdown and sheltering in place, but on the external force, there is still a contraction of social programs. All of this has led to concerns for increased suicide risk. Despite all this, we hold hope that we will get a miracle COVID vaccine. But as we all know, we live in a world where not everybody gets vaccines, not everybody wears masks. So the attitudes will persist even once we have a vaccine in place. Next slide. Well, going way back to March, we can remember how silly and ignorant we were. And we made a lot of assumptions based on our past experiences with H1N1, West Nile virus, the various influenzas, and SARS. And we made some predictive information about how we thought patients would respond to this virus and some of the initial data that we had gathered about the virus. And I won't belabor this because I think we've heard it in a much better fashion from our previous speakers. But just to say that patients who are immunosuppressed do have an increased risk of contracting the disease. As we thought, the severity of the disease is not as profound as we may have initially thought, but there is increased morbidity and mortality in the transplant population, both adults and pediatrics. In the background and setting of the challenges that we have experienced so far, CMS has deemed transplant to continue to be an essential service, and thus organ donation and transplantation have moved forward despite some of our early assumptions and fears. Next slide. Well, in a perfect world, we would do what the NBA has done. We would create a bubble where everybody inside of this bubble would be routinely tested on a daily basis. No one would have any interaction with each other, but we would yet somehow be able to go on with our activities of daily living and know that we were completely sheltered away from other individuals who may contract the disease. Others who had been tracked with the disease would then be quarantined in an area where they could either be treated and or just ride out their sickness. This unfortunately hasn't been able to happen in our country, although it has been successfully piloted in other countries. Looking at some of the available information that's online to predict the infection risk, and I bring this up only because on a daily basis, it's an ever-changing spectrum of how risky the world is around us. So I would just draw your attention to a couple of easy to access online risk calculators, one from the Cleveland Clinic, one from UPenn, the CHIME calculator, and then the CDC risk calculator. Next slide. The relative risk of returning to activity has been captured by the University of Texas in a brief sort of stratified study that they put forward. Interestingly, the circle demonstrates the risk, or I should say relative risk, of returning to school, camps, and outdoor activities for children. As you can see, it's been slated as a relatively moderate to high risk venture to go back to school, and of course this is more than likely specific to Texas and the hotspots that are present in that state. Next slide. So as far as the OPO and liver program performance, on the UNOS website, what we can see is that over the course of the early months of March through June, there was an initial dip in pediatric transplant and organ donation. That has steadily started to increase since May. And some have reported that as late as July, we have returned to pre-COVID status as far as liver donation and liver transplant. As others have stated, living donation has had a slight respite, but has again started to reemerge as a standard of practice. In my region in Northern California, throughout the course of the COVID early pandemic, there was essentially no real change in practice. So there have been effectively 150 liver donors since March, or I should say late February. The only changes have been identified as decreased DCDs initially in the late months of March, moving into April. There was a dip in donation transplant, but that rapidly recovered by the end of April, moving into May. When stratified, most of these transplants occurred in the critically ill patients who had Melden-Pelt scores of high acuity. Next slide. In decision making, I think it's appropriate that we, when we're talking about reentry and reemergence into sort of full-time transplant and doing all of the higher risk operations and patients that we have of high acuity on our list, I think it's important to take into account the aggregate risk. When you think about the risk of an organ donor and that donor's family and the medical care team that is taking care of that patient, and then add to that risk the risk of exposure for procurement teams, the hospital OR teams, and then everybody that they come in contact with, and then multiply that times the individual risk of any organs that would be transplanted from a pediatric organ donor. I think it gives you a broader and better view of what the actual risk could be in attempting to save a child's life through donation and transplantation. Not to say that this is a very worthwhile venture, but to capture the full risk, I think that we need to not only target strategies and protocols to alleviate exposure in all of these areas, but also continue to monitor and reassess the safety of these various areas of practice. Next slide. I bring this slide forward just as an example of one of the risk strata that could be entertained for looking at the potential risk of surgery as we talk about reentering. Go ahead and go to next slide. There's another animation there. This MENT score is a score that was generated by the Department of Surgery at the University of Chicago and published in the Journal of the American College of Surgeons as a risk stratified score looking at not only the stratification for the actual procedure, the disease involved, and some comorbidities associated with the patient. The idea being that there is a ethical and efficient estimation that you could produce to optimize the resource utilization and minimize the provider risk. Review and application of the stratified scoring system for operations that you deferred versus those that were performed were compared in a group of surgical patients conducted through March of this year. What they found was that higher scores were associated with worse outcomes, increased exposure risk, and higher resource utilization. When you stratify organ donation and transplantation into this model, you find that it occurs much at the higher end of this scoring spectrum. Next slide. So when we talk about fundamental considerations for reentry, I think it's imperative to have clear objectives based on the available data. And I put available data in quotations because that data seems to be changing practically hourly. Clear and transparent risk stratification for every step of the patient path, I think is also critical. customized step-by-step plans for organ acceptance for patients from the time of organ acceptance to the time of discharge is also imperative. All of this strategy has to be designed to minimize risk of COVID exposure, obviously utilizing all of the distancing, mask wearing, hand hygiene, and other preventative measures that we have come to live with at this point. Optimizing resources so that we're not back in a world of no available PPEs and toilet paper in the grocery stores. Having an effective disaster plan and a disaster planning team composed of administration, multidisciplinary teams, community leaders, and of course, and most importantly, our parents and patients, because they are the most effective individuals in executing any type of disaster plan for our pediatric patients. A frequent reassessment and refinement of the program and design, which allows us to reshift our attitude and approach beyond just the financial considerations of reentry into activities of life. As physicians and healthcare providers, we need to continue to advocate for government support for our families in need. Many of these social programs that are available for children are unfortunately tied to their schools. Many of their meal opportunities obviously are tied to school. So without those sources of community resource available, many of these children are at risk. And most importantly, we just have to continue to ask questions and ask more questions and ask more questions and encourage our parents to ask those questions as well. Next slide. So when considering the re-entry, obviously one of the things that we get asked most frequently is about the re-entry for our kids to go back to school. When can we get these kids out of our house and back into the school program so that we can get on with our lives? And there are obviously many components and factors that go into that decision, and many of those factors and components are very geographic based and based on the incidence of disease in any particular locality. So I pose these special considerations with the full disclaimer that all decisions and options should be discussed with a patient-specific transplant professional. These are not recommendations, these are not even guidelines, but the Pediatric Infectious Disease Society has worked diligently to generate some frequently asked questions, and I got their permission to just paraphrase some of the comments that they made in a recent paper submission. And so I would just encourage you that in speaking to patients and families to practice some of the more commonsensical things that we've discussed. I think it's appropriate in looking at this that there are liver transplant recipients that are out beyond 6 months are more than likely safe to go back to school if they've met some of the underlying criteria stated here. Next slide. So I feel like I've hit with a lot of doom and gloom and all the external and internal pressures that are impacting us, and the real pain that the patients and parents are feeling at this time beyond just their medical conditions that we've described. And so I just like to close out on a bit of a positive note and say a special thanks to those who have taken this time to reflect, recalibrate, sort of redirect and act as advocates for children. I put better, and I left this blank intentionally because whatever that means to you, better is on the other side of this adversity. This is really not so much of a re-entry into the normal that we've known in the past. Those strategies and practices are obviously going to be inadequate for the weight challenges and goals that we're facing moving forward. So I really more like to recalibrate this re-entry as more of a re-emergence. So thank you very much.
All right, we will now begin our panel discussion. And we're joined now by Dr. Vicky Ng from University of Toronto Hospital for Sick Children, as well as Mercedes Martinez from Columbia University, New York Presbyterian. So on everyone's mind, and the most popular question today, as well as every day in our clinics, what are you guys actually telling your patients in different regions about going back to school? Jamie, what are you doing in New York?
I think just as Dr. Kelly so eloquently described and laid out, it really depends on the specific region, right? And the local prevalence of the disease. And so we are, in New York, kind of holding our breath, seeing what's going to happen. We're in a good place right now. But I think just as Dr. Kelly laid out, it all depends on the time from transplant, how that patient is doing. And right now we recommend that if your local schools are opening up, that we think it's probably okay for our post-transplant patients to go back.
Can others chime in on what recommendations in particular you're giving patients who are going back to school?
I think we've seen even in, during the peak of COVID in New York City, and Nadia and Mercedes can also chime in here, PPE works, right? So it's wearing your masks, it's washing your hands, it's keeping distances. I think the same holds true for schools, and this is not even the students being in a COVID unit. I think that the decisions, it's very unique to family situations, whether they have an elderly grandparent that lives in the house too. I think that we have to kind of, we can give our best recommendations, but a lot of the families all have unique situations. So it's kind of up to, there's a whole host of factors, but I think that good hygiene, and it's tougher for the little ones to do that. But I think that that's our recommendations, at least from our center.
Mercedes and Vicky, could you chime in, especially also about what patients do who have siblings that might be outside of the house or other family members?
Then I think that this is maybe one of the most difficult questions to answer. Sometimes you tell the parents of a liver transplant recipient, maybe if you don't feel like they need to go to school, it might be safer for them to stay home. But then if they have 4 siblings that go to school and those siblings might bring the coronavirus back, it's very difficult. Then I really think that also depending on the age, it might be easier to tell a 10 or 12-year-old wear masks and be careful and wash your hands than telling a 6-year-old to do that. I also think that it's very important, the incidence of the virus is very important, but also it's very important, I tell the parents, get involved with the Board of Education. Try to see what the authorities doing to limit the amount of kids in the school. Make sure that they have way to perform high hygiene. Try to talk to the school and see what they are doing for lunchtime. Are the kids going to stay at school for lunch? And because at that time, mask doesn't work and kids tend to share what they bring and what they eat. Then I think that all this, and I usually give like a broad recommendation. And at the end, it's up to the families to decide. And I really think that this is good, true for the liver transplant recipient, but I really think that we also, and this is a discussion that we started this with, what are we going to tell to those patients that are obese with fatty liver? We saw in the register that patients that have significant liver disease or some kind of degree of liver disease maybe have worse outcome and worse disease that the patient that actually have our liver transplant recipient. Then we started the discussion this week because I think that if the patient have an advanced liver disease, are more likely to tell their family, don't send the patient to school, than actually a transplant patient that is stable on medication. But again, have to do with the incident in an area where the percentage of positive virus test is only about 1% or is 2%, the incidence is not that high. Maybe the risk is not that high. And also have to do with how is the school dealing with that. If they are bringing everybody to the school, 30 kids in the class, might not be ideal, even if the incidence is low.
I think I would echo everything, Emily, that Mercedes has said. I think it's really hard to extrapolate from one jurisdiction to another, and certainly from one country to another as we're north of the border. I think the second thing I would say is that there's still a lot of uncertainty here in Canada. The first day of school is actually the day after Labor Day. So at the Hospital for Sick Children, we realize that, every day, every week is a new surroundings. So we're trying to really sort of lay a framework of really having our parents realize that they are not alone, but also to really consider the framework, right? They speaking with your transplant professional for your own patient's risk, but then looking at the community and just looking at the specific school in your neighborhood and their ability to do all the things that have already been stated. The only thing that I will say that's unique right now in Canada is there's still a lot of uncertainty about doing hybrid models of returning back to school, with some ideas of maybe doing sort of like, have the kids go on certain days of the week to try to enhance the opportunity of physical distancing. So these are all just really unique things of the general principles that have already been outlaid. But for any parents who are listening, to realize that this is really a partnership, and to really just sort of continue the communication within your community and within your jurisdiction. Thank you.
Have folks dealt yet with patients who do have COVID infections, and thinking about whether you empirically reduce the immunosuppression or wait and see? Maybe folks in New York, especially, who have had higher prevalence in their communities?
Then I can talk about that. And I really think that we don't know what immunosuppression do to this. If a patient is on a stable immunosuppression for years and have a mild disease, I will not recommend to make any of those changes, because the last thing that you want to do is reduce the immunosuppression on a patient that might never get significant disease, and then they develop rejection, and then you are in a worse situation. We have experience with a small baby. We published our case and people can read about it. She has COVID day 4 after the transplant, and the first biopsy read hepatitis, viral hepatitis, and rejection. And we slightly increased her immunosuppression at the beginning. The liver test got worse. Then we lowered the immunosuppression. We stopped the MMF. And her liver test got better. Then the viral hepatitis got better. But at the end, about 30 days after, she did have rejection again. And we were able to control. It's a fresh post-transplant. We are checking blood work every week. But that's not the same for somebody that is stable many years out. You might not be as vigilant. Then I think that you have to be really smart. If the patient is sick in the ICU with COVID, absolutely. You are checking liver tests every day, and that patient's life is on the line from maybe the infection. But if the patient is stable and have a very mild disease, I will not recommend to make any changes.
We also have not seen any presentations of MIS-C in children who are solid organ transplant recipients or those on immunosuppression. So there may be some protective factor there as well. I want to ask our panel, how has telehealth affected your practice in hepatology or transplant right now? What are people doing with outpatient transplant evaluations? Emily, how are you guys dealing with it in California?
So I know we're doing a lot of telehealth. We are still doing a lot of telehealth, and I think it's an ongoing balance of how much we can do by telehealth and when do we really have to see people in person. We're, I think, a little bit following the lead of patients. If they feel like it's really important to come, then we'll do that. But we're also encouraging, people to stay safe and prevent transmission in these kids who are getting close to liver transplant, and families that are trying to help keep everybody safe. So we are starting things by telehealth and doing what we can by telehealth, and then bringing folks into the clinic to complete things or have final discussions.
Yeah, I really think that
has
in the past,
being affected in Canada, what's your impression of what's going on over the past couple of months?
Thanks, Nadia. I think the COVID-19 pandemic has really created unprecedented circumstances and unique challenges, and Canada is absolutely not exempt. I can say that, similar to the world, we are finding that kids are disproportionately not affected in terms of the really seriousness of the disease as a general pediatric population. That said, I think in terms of pediatric transplantation, just briefly, we have a liver transplant program for adults in every province of Canada, but there are only 3 pediatric liver transplant programs in Canada, in Ontario, in Quebec, and Edmonton in Alberta. None of the pediatric liver transplant programs were closed. There were at least ranging from 2 to 7 transplants in the 3 months of April, May, June, hot during the COVID time. And that actually interestingly represent 20% of our year's average. So we were just probably a little bit shy of a quarter of the transplants we normally do in a year in these 3 months. So I think that the main thing I'll also say is that there was a little bit of variation in terms of people's willingness to do live donor liver transplants. I can just say that in Toronto, we 60% of the transplants we did during these 3 months were actually live donor due to very sick kids. And I think that's reflective of what I think Dr. Kelly was saying earlier with decreased donor rates. So I think one of the most interesting messages I would say for the liver community is it seems to be that while kidney transplant programs were closed, the liver transplant programs were not closed during this period. I'd be curious to see if there's any experience from my U.S. colleagues with regards to closing of programs within cities that had multiple programs to allow the larger programs to do the transplants.
Then I can talk about that. Then regarding the closing program, we never closed the program, but there was a window of about 6-7 weeks that we didn't get any organ offer. We didn't have any critical patient, and it was almost impossible to do living donor. The adult program was it was totally COVID, and we were concerned about bringing a healthy donor to do a living donor when the recipient, we didn't have any urgent, the patients that got sick and needed a transplant got transplanted. But there was about maybe 6 weeks or so, 6-8 weeks that we didn't have any transplant. The last living donor that we did was that patient that we did in March 19, and she got infected. We think that she can infect it from home because 4 days after the transplant, and the father has it, the grandmother has it. We didn't have the capability to test the donors at that time. It was at the very beginning, or the recipient. We didn't test anyone. We didn't expect it that it was so prevalent in New York, and we were naive. And then after that, there were about 6 weeks that we didn't do anything, but patients start coming back and being sick. And we have done about 4 cadaveric donors and 1 living donor since I think that mid-May. Then we are open. We always saw patients in clinic, and again with the evaluations, we try to minimize the time in the hospital. We do as much as we can via telemedicine and bring the patient to the hospital one day to be examined by the surgeons and the physician and to do the tests that needed to be done in one day.
You know, one of the things that helped.
Oh, sorry, go ahead.
No, go ahead. Mount Sinai was that during our peak, where, as Mercedes said, there was COVID everywhere in our hospitals, our adult colleagues had set up a separate area and reopened a whole PACU type area to make it a transplant ICU. And this was a COVID-free area where there was no COVID patients ever admitted to here. And it was actually staffed by our transplant surgeons. They were doing 12-hour shifts, you know, working as ICU doctors or ICU fellows, really. You know, our outpatient nurses then staffed this. And we also, on the ped side, really did no COVID testing at all anywhere near our outpatient clinics, right? To keep that as COVID-free, even for pre-procedure COVID testing, that needed to be done at the pediatricians or in an outpatient setting, and they could not come. So that was helpful to us to kind of help create barriers to, you know, the infections to our transplant patients.
Okay, one last question. What are you guys doing to get your practices and your patients ready for this concern about a potential new wave in the fall and winter when flu returns and the infection may return also? Noel or Mohi, do you want to speak to that?
Noel, you're muted.
Oh, sorry. In terms of how we're preparing patients for the second wave, I think some of it is using an opportunity to do some things now. You know, most of it has been via telehealth, to be honest. So our clinics are fully open at this point. We do see some patients in person, certainly the fresh post and those that need to be seen, but it's all telehealth. So I think thinking about things that need to be done for patients in this window prior to the second surge. Other than that, we're just making sure that we're fully capable from a telehealth perspective, that everything's as safe as possible for patients coming into the hospital. I think those are the only minor modifications.
Ade, can I say a couple of comments as well?
Yes.
Oh, I was just going to say that, and we all know, and I think we were hearing, especially if we're talking about the post-liver transplant population, that generally speaking, the sequelae seem to be mild. I really want to highlight something that I think we're seeing across all pediatrics is the impact of this pandemic on children's mental health and emotional well-being. And I think we all know that, general wellness actually is a multidimensional sort of approach. So I think the one thing that we're really sort of being attuned to is just really the whole idea of these patient-reported outcomes and just trying, how do you gauge that in a telehealth way? We may be very happy that their labs are fine, that they have no symptoms clinically, and parents aren't really seeing anything physically. But I would just probably use this forum to try to be creative with our very committed and expert multidisciplinary team members, that we actually find different ways to actually probe and make sure that our kids are okay. And that would be probably the additional plug I'll put in the challenges that we're facing with telehealth. Thanks, Emily.
Absolutely. No, I think that's really important, that in addition to caring for liver disease, we're caring for kids and their families, and they have all the same sort of issues and concerns that all kids and families do. Well, on that note, I think we're going to wrap up. We immensely appreciate the speakers and the panelists and all the attendees that we have had today. Can we have the acknowledgement slide? See if it's otherwise pressure on me to make sure I thank all the right people. So Dr. Coley and Dr. Leung in the AASLD Pediatric Liver Disorder Special Interest Group, Dr. Georgie Becerra and the AASLD COVID-19 Clinical Oversight Subcommittee, which helped us organize this webinar in advance of us needing to help families get their kids back to school in particular. And then our collaborating organizations, including Karen Murray, Ben Gould, Mercedes Martinez, and the NASPGHAN leadership, as well as Vicki Ng, Bo Kelly, Steve Librito, and the SPLIT leadership, and then the AASLD staff that helped in the organization and production of this webinar. We really appreciate everybody's time, and hopefully we can continue this conversation going forward. Thank you.
Definitely.
Thank you.
Thanks so much for the opportunity. It's great.
Good night, everyone.
Night.